Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. So, David, long COVID today.
I know, John.
Very important and very difficult.
It is a hard one, John. You know, it seems like we've been living with COVID long enough, but now we hear about long COVID, and maybe that's going to be around forever, at least for certain people. I actually was worried maybe I had it, after my bout with COVID. I feel like I'm pretty well recovered now, but it can pop up even later on. So it's one of those topics, not a fun topic, John, but I think it's an important topic.
Well, I don't think it's been covered very well, but maybe we should start by trying to put a box around what actually is long COVID, such as we understand it right now.
Good. Well, you're going to put the box around it, John? You'd like to answer your own questions sometimes.
Well, I think all the time, David. I think long there is obviously everyone knows that there was this acute burst of COVID with multiple variants, and we spent a lot of time focusing on that. But long COVID reflects those people who, 30 to 60 days after recovery, after having a negative test, have a series of common symptoms that range from respiratory ones that you might have, like shortness of breath and fatigue because your respiratory system's been affected. Let's say your lungs have been scarred.
John, how about shortness
fog.
of patience? Can I blame that on COVID?
You had that before COVID, so no. But you've got a whole series of it. There's some suggestions that there's some inflammation of the heart. There's some muscle pain. A lot of things that would be very similar to chronic fatigue, but with some very specific things like inflammation of the heart, tachycardia, palpitations of the heart, and lung scarring that continues. And the weird thing, David, is with all of it affects about 40% of the people who've had COVID globally. About 30% of the people in the U.S. have some symptoms of long COVID, and it's sort of unclear why it's unclear what's going on with long COVID right now.
John, one of the interesting things about it is really not just people who had severe illness. When I was sick, it took me quite a while to recover, but it was just, okay, this is like the idea of like a lingering cough or lingering fatigue or something like that. But here we're talking about somebody who maybe didn't even have it that much, didn't have it that severely in the acute phase, and they may have it longer. That's one thing that's interesting.
Oh, it's very strange. You can have people who were largely asymptomatic, who had a positive test, who then get the symptoms that are persisting for a long time, and people with very acute phases, even hospitalized, who have no long COVID symptoms. It's a peculiar disease. It hits in a way that it did not weigh on for other aspects of COVID, kids as much as adults, and long COVID also is more typically hitting women versus men. Now, there clearly are some peculiarities that make this subset of COVID really different, and yet we're really not studying it.
Well, John, there's about a range of people affected. The estimates in the U.S. is something between 8 and 23 million people. It's a lot. When we're one of the places that I did hear about it early on was in trying to encourage younger people to get vaccinated. And the argument was, hey, younger people, you may not have had it very severely. You could actually have long COVID, a fairly high percentage. I heard numbers like 30% at the time. So it kind of ties in. Now, maybe it's not being studied that much, but it is being.
Well, but you're on a before you go there, David. There's one important point there, which is that there is plenty of evidence that vaccination either lightens the impact of COVID, but also reduces the likelihood of long COVID. So if these kind of brain fog, fatigue, heart problems, respiratory problems, potential sort of depression and aspects of other autoimmune diseases aren't very attractive, perhaps you should get your vaccination.
So this is one of the reasons when you talked about studying it, that is very important. So we heard, when the vaccine came out, some people already were having what they were describing as long COVID at that time. And some people reported kind of anecdotally, gee, they got the vaccine and they got better. Well, who knows if that was the cause of it or not. There's a 40,000 person trial that the National Institutes of Health is running, spending $1 billion on it, called the RECOVER trial. And that there's some argument, even our buddy Zeke Emanuel thinks that may be too small of a trial and not enough money spent here.
Well, come on, given the tens of millions of people domestically and abroad who've had this, it seems kind of trivial in retrospect. I mean, you think with 8 to 20 million Americans, we'd be investing in hundreds of thousands of studies and taking advantage of all of these multi-specialty clinics that are popping up at different hospitals, particularly at research institutions that are there to really care for these long COVID patients and are getting data. We're not sharing that data. It does feel like it's important. Look, $1 billion in the NIH and doing a study is important, but I think this is sort of a rolling crisis that is under the radar, perhaps because it just hasn't it hasn't affected as many people, and we're still in sort of this rolling acute phase with BA2. But we actually have this live fire example of people getting care, getting sick, trickling into this long COVID phase without a systematic surveillance and access to data that would allow us to actually kind of break it into pieces and figure out how we're actually going to solve. That's a lot of sick people, Dave.
John, the Biden administration, to its credit, on April 5th, did issue a presidential memorandum where they're trying to get kind of a whole government effort, as they call it, for prevention, detection, and treatment of long COVID. Now, that includes some things that were previously announced, like that RECOVER study that I mentioned. It includes some new things as well. And I guess if you don't think $1 billion is enough for the RECOVER trial, you probably don't think the $20 million for the Centers of Excellence to promote evidence-based care of long COVID is sufficient either. But that is one of the things.
Well, I think that's a start. I mean, but you'd want to base it off of as much information as you could get. I mean, there's a lot of people with long COVID getting care with the government paying for it, and it just strikes me as crazy that we're not systematically pulling
John,
that information.
Let's talk about some of the systematic things that either are in place or are meant to come into place as part of this memorandum. So the VA, of course, treats many people with COVID, and there is a clinic network, and they have good information systems. So there's an expansion for treatment and learning for that network. They're making sure that health insurance actually covers long COVID. Can do that by making it part of the essential health benefits under the Affordable Care Act, making sure federal employees have it, that's part of Medicaid, and so on. And importantly, actually soliciting feedback from people who are living with long COVID.
Well, I think that's all well and good, but there's also some activity among doctors to create a separate ICD-9 or diagnostic code so that we could track it as a specific, when you get sick, there are these diagnostic codes that when you're getting care are tied to your bill. So we could, we're not even cleanly tying the care to the people who are getting sick. There's plenty of evidence that this is not a short-term phenomenon. Other respiratory diseases, coronaviruses, MERS and SARS, that were quick bursts of epidemics. There's a long tail there. I just think there's a lot. We need to look at this not as a subordinate priority, but really elementally part of how we manage COVID. If COVID is going to be endemic by the end of this year, and one out of every 3 people who get COVID, and it's probably lower than that among the vaccinated, but a significant number are going to get it every year. We have to start to study this and figure out how to solve it, because what those symptoms turn into is someone who can't productively work, can't effectively care for their family members. It's quite a big deal. And there's been so much noise appropriately and priority spent on just breaking the next wave. But there's this growing long-term, human cost that I think, look, we figured out the vaccines. We could probably crack some of these long COVID cases, but we need to tag the data, measure what's going on, and then start to study it in a rapid scientific fashion.
Well, John, you're wandering over into the place where long COVID actually becomes, sad to say, political. And that is whether we're talking about people having COVID for a long time, whether it's a disability and whether that should confer certain protections on them. There's actually part of this memorandum is pursuing federal protections to treat long COVID as a disability.
Today, I think it does. I think it does qualify as a disability today. I think it does. There may be some battles over that. There's been a significant Republican pushback on the expansion of the disability category. In some cases, I think some legitimate questions were raised about whether we've so expanded it that the category of the disabled in order to access federal support is maybe too great. But that's very different than looking at these, in some cases, catastrophic cases of people who can't breathe, can't taste, can't smell, who've got serious heart issues, can barely get out of bed. I would think that would clearly meet the qualification for being
I think
disabled.
If you look at it on an individual level, you're going to see that. On the other side of it is that people who maybe have mild long COVID or maybe have something else, this may contribute to what was already an issue about the number of people applying for disability and dropping out of the workforce, which is a challenge, especially as we face labor shortages and there's not a lot of immigration going on. I think these things all kind of come together and is part of what we're seeing, in fact, now with the challenges and inflation in the economy.
Well, gosh, that's 15 different points that not always relate to the question. But getting back to the question, that if we don't put enough money towards studying long COVID, we're not going to be able to solve it, and you will lose more of these folks from the workplace. But there's clearly levels of disability that long COVID is not. And by the way, not all cases. In some cases, it's mild long COVID. To your point, it's loss of smell or taste, or there's a little bit more discomfort and joint pain, or you have a little bit of a harder time after going out to exercise. But there are other folks that it's pretty catastrophic. They can't breathe and they can barely move around. And I think we need to study it in order to solve it. And I don't think you need to roll that up into a grand set of references to about the economy. I mean, can you stay on?
Sure, John.
Please?
Let's finish off with a question, a little prediction, and lay down a marker. Okay, 5 years from now, will we be looking at long COVID like a big chronic illness, let's say like diabetes, or it will be more like something like chronic fatigue syndrome, which you hear about but doesn't actually get that much attention?
I think you're going to split it into two different categories. Those that we can address through therapeutics and all these great biologics and what we've learned in terms of vaccines and treatments for COVID. They've come rapidly. And I fear that there will be a category that'll look just like that chronic fatigue that may or may not be getting the attention it deserves, but that is really disabling for people.
Well, John, I'm going to go all the way in the other direction and say we're not going to be talking about long COVID at all because we're going to have solved it. And when we do that, it's also going to sweep up chronic fatigue syndrome and some other related syndromes in its wake. We're going to deal with those too, and it's going to be a big nothing, and we'll be on to other problems. So before you can tell me my question was terrible and stupid, etc.
Good luck, Mr. Techno-Futurist.
That's good, John. I'll visit you in my self-driving vehicle, and we can compare notes at that point if we're still allowed on the road. In any case, that's it for yet another episode of Care Talk. We've been talking today about long COVID. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. If you like what you heard or you didn't, please subscribe.